The truth is, I really started this journey in breast cancer because I lost an aunt due to breast cancer about 28 years ago. And I suddenly realized that I almost had a responsibility to do something. And as a biomedical engineer, I think one of the things biomedical engineers are good at is to be able to really hone in on what that unmet clinical need is. What is that unmet clinical problem? And so I started to put my thinking hat on, and working with clinicians, we basically came on the idea that AI could be used as a way of providing frugal, opportunistic, and low-cost precision medicine. Not precision medicine that's going to cost $4,000 per patient, but by analyzing images of a breast biopsy, we could now do this for pennies on the dollar, right?
Welcome to Holy Shift, Biomedical Breakthrough Shaping Tomorrow. What is biomedical engineering exactly? It's about engineering solutions that improve human health, from new medical imaging tools to personalized cancer treatments. Holy Shift reveals the people, passion, and purpose powering the future of biomedical research. Welcome to Holy Shift. Today, we are joined by Dr. Anant Madabhushi, a professor of biomedical engineering at Georgia Tech and Emory, and a prolific researcher who has literally written hundreds of scientific papers, which he squeezes in between cricket matches. His research develops artificial intelligence, think a medical version of ChatGPT, to help physicians diagnose all sorts of cancers more quickly and accurately. His AIs look at pictures of medical records and blood samples to uncover hidden patterns that are often too subtle or complicated to be seen by the human eye, but are telltale signs of something going wrong in the body so we can stop it early. Let's get into today's episode of Holy Shift with Dr. Anant Madabhushi. Well, good almost afternoon. Good morning.
Good morning.
Thank you for joining us today. Can you introduce yourself and also start by telling us a little bit about the work that you do here?
Sure. My name is Anant Madabhushi. I'm a professor of biomedical engineering at Georgia Tech and Emory University. I came to Atlanta about 3 years ago, and one of the reasons I came was to launch the Empathetic AI for Health Institute. And I'm very proud to be the director of the Empathetic AI for Health Institute. A lot of my work is really focused on developing, innovating, and applying novel AI technologies to further precision medicine, specifically healthcare medicine. How can these technologies really move the needle forward in better diagnosis, better prognosis, better prediction of therapeutic response, therapeutic benefit for patients with diseases like cancer, cardiovascular disease, Alzheimer's, and kidney disease.
Okay, so we're going to break that down a little bit. First off, I've been dying to ask this. What is the empathetic part for the AI? How did that name come about?
So the name, I think, was very intentional. So just by way of background, I think I should probably start by saying I'm a very proud immigrant, grew up in India. And as an immigrant growing up in India, then coming to the United States now 27 years ago, I started to acutely appreciate the opportunities that the United States offered, but at the same time also really gave me a lens into the huge disparity that we had between sort of the first world and low middle income countries and other parts of the developing world. Started to appreciate that there was a real opportunity with artificial intelligence to sort of help level the playing field a little bit. And as I started to think about a name for the institute, I started to recognize that empathy was really at the core of it. And this is not just in terms of the global population, in terms of low middle income countries. As I look around, and having lived here for a while, I appreciate even the disparity that exists between, say, rural America versus urban America. You know, the challenges with access to resources that a lot of our rural populations face. And start to appreciate that AI could really provide novel, a term that I'll probably come to a few times during this interview.
And novel being new and unique.
Novel and new and unique, but also frugal and opportunistic. And what I mean by that is using AI with routinely available data and asking more questions from that data than was originally intended when that data was acquired.
Which is the money saving component
The frugal,
of it, right?
the opportunistic piece.
Is because the information is out there and you're utilizing artificial intelligence to look at that data that information we already have.
Yep.
And then take that. So you're talking about prognosis. Tell a little bit more to those who wonder, what does prognosis mean?
Yep,
and also precision medicine.
Yep.
Those two things. How do you tie in that data then? And what does prognosis mean? And how is it impacted? And then what is precision medicine?
Absolutely. So I'll give you a very tangible, specific example with the prognosis. So just about 3 weeks ago, we published a paper. And the paper really captures this idea of opportunistic and frugal. We showed in this publication that with application of AI, we were able to look at routine images of the eye. Every year,
and those are like, yeah,
those
every
are standard fundus images. You go in to see your ophthalmologist, your eye doctor to get a vision test. They take one of these images. Now, these images are very useful because obviously they give you a sense of the health of your eye.
Now, is this the image where they dilate your eyes and then you can't see for the rest of the day?
Yeah, well, maybe about 30 minutes or so. But yeah, it's an image of the eye, and
yes.
You basically get to see the vessels in the eye, and the eye doctor will look at that image and essentially get a sense of just generally how the health of your eye is. The breakthrough we made in this paper was the fact that by looking at these images that were required to assess your general eye health, we were able to find patterns relating to the vessels with artificial intelligence that could tell us in patients 10 years prior to diagnosis that they were going to develop cancers like multiple myeloma, lymphoma, and leukemia. 10 years before that actual diagnosis.
And that's where the prognosis comes in.
That's where the prognosis comes
yes.
in. And that's where the frugality and the opportunism comes in, because that image was acquired as part of your routine annual checkup. But with the power of artificial intelligence, we're able to go in and ask a whole bunch of more questions from that data than might have been addressed had it been solely used for the purpose for which it was taken.
Right.
And so that's the frugality, that's the opportunism piece. Now, precision medicine that you touched on is really important. Now, broadly speaking, what precision medicine means is that if you've got an individual with, let's say, breast cancer, we want to figure out what is the right treatment for that individual. Should this individual get chemotherapy? Could they possibly avoid chemotherapy? Now, we made some advances there for some of these diseases, but the truth is that a large part of medicine doesn't actually practice precision medicine.
Right.
Because
they're looking for the general, what's going to help or what's going to be an impact, we think, on a gazillion people. I'm using a crazy number, but...
Yeah, so right now, the rubrics that we have or the tools that we have to really help identify the right treatment for a given person is based on fairly crude metrics. We use stage of the disease, which really basically tells you about how advanced the cancer is. Mm-hmm. Now, stage is helpful, but the problem is that several people with the same stage of disease will have very different courses of the disease progression, and the way they respond to certain treatments may vary dramatically. I'll come back to breast cancer. So if we talk about early stage breast cancer, it turns out that 70% of early stage breast cancer patients may not actually require chemotherapy.
Wow.
Right? The question is, how do we identify
those versus the 30%?
Right.
Yeah.
Now, why do we want to do that? Several reasons. Chemotherapy is toxic. Chemotherapy causes hair loss, causes nausea. Plus, it's not cheap. It's $30,000 per patient per year. And again, wearing my immigrant hat on and thinking about my native country of India, the cost of chemotherapy in India is still considerable. It's still about $2,000. Now, when I started to work in this field nearly 20 years ago, one of the first things I appreciated was that in the United States, there was a test, a molecular test, that allowed you to identify which women were going to benefit from chemotherapy and which women were not. So this was great. When I started to talk to breast cancer doctors, they said, well, this is great, but the problem is this test is not exactly perfect. Plus, it costs $4,000.
Wow.
And it involves destruction of the tissue.
Right.
And about 17 years ago, we came up with the idea that if you looked at an image of a breast biopsy, that there were patterns in that image of the biopsy that could actually tell us about the aggressiveness of the breast cancer. We could now figure out which women had more aggressive breast cancer, which women had less aggressive breast cancer. And therefore, we could now potentially start to stratify which women were going to benefit from chemotherapy versus those women that were not going to benefit.
And stratify is basically just separating them into different groups.
Risk groups.
So that risk groups.
Correct. So you have stage, that is one way of compartmentalizing
how far along
patient
it is.
risk.
Right.
But there were patterns in the cancer that we were able to hone in on with the AI that potentially did a better job than stage. Because remember, these are all women with early stage.
Right.
But even within women with early stage, we clearly see that there are women with more aggressive courses of the trajectory of the disease, and there are women with less aggressive disease. There are women who are going to benefit from chemo, there are women who are not going to benefit from chemo. And so with the AI, we were able to find patterns within the cancer that could now start to provide, it's almost, you think of stage as a bucket. And what the AI was doing was saying there are smaller buckets within that larger bucket, and there are smaller buckets where some of these women are going to benefit, but there's another bucket where women are not going to benefit, even though they all fall into the bigger stage bucket. And so what AI was really doing was breaking out smaller compartments within that larger bucket. And that's really precision medicine, right?
Yeah.
But
And I
we were
think
able-
that, like,
yeah.
when I think about being a woman, right? If I were taking chemotherapy and I was in the bucket that I wouldn't benefit from it, right? If you knew that, which you won't, right?
Yeah.
But all of us know how awful a life experience that is.
Yeah.
So if I had the ability to skip that and maybe go to a different type of treatment that would work better for me, that is huge.
Yeah, absolutely. And the truth is, I really started this journey in breast cancer because I lost an aunt due to breast cancer about 28 years ago. And that, to me, was a point where I looked back and said, I have to do something. I'm becoming a biomedical engineer. I was in the process of training. I was doing my PhD at that point. And I suddenly realized that I almost had a responsibility to do something. And as a biomedical engineer, one of the things, if I might, I think one of the things biomedical engineers are good at is to be able to really hone in on what that unmet clinical need is. What is that unmet clinical problem? And so I started to put my thinking hat on, and working with clinicians, we basically came on the idea that AI could be used as a way of providing frugal, opportunistic, and low-cost precision medicine. Not precision medicine that's going to cost $4,000 per patient, but by analyzing images of a breast biopsy, we could now do this for pennies on the dollar, right? Because again, you think about the global context, $4,000 test in the United States to save somebody from $3,000 worth of chemotherapy is great. But $4,000 to save you $2,000 and $1,900 worth of chemotherapy doesn't make a lot of sense in India. And so that's where you need a test that might cost $20 or $30.
Right.
And that's where the AI comes in. So it's frugal and it's opportunistic.
Yeah. Okay, so you spoke about why you're passionate about breast cancer. Tell us what motivated you to study biomedical engineering in the first place.
Sure. Well, the story is quite simple, really. Growing up as a kid in India in the 80s and the 90s, your parents were very clear with you. They really gave you a couple of options. They said, kid, you can go do whatever you want, so long as you're either an engineer or a doctor. It was very, very simple.
Yeah.
It was very, very clearly laid out. Unfortunately, my sister, who was a vascular surgeon, is a smart one who got the grade to make it to medical school. I wasn't that smart. And so I narrowly missed out on getting into medical school. But I was very fortunate that in the early 90s, biomedical engineering had started to arrive, on the scene, and there were a few biomedical engineering undergraduate programs in India. And so I was very lucky to actually be one of the very, very early enrollees in biomedical engineering in the early 90s in India. And one of the other reasons I got into this field is because an uncle of mine who was in the United States, who had heard from my father that I was really disappointed about not getting into medical school, wrote to me, and he sent me a Webster Biomedical Engineering Handbook. And he said, take a look at this. He was a biomedical engineer himself. He said, take a look at this. And he said that, yes, I understand that you're disappointed about not getting into medical school, but you have an opportunity here with your skills to become a biomedical engineer, and guess what? You can add significant value to what physicians and clinicians and doctors are doing. And I think at that point, sort of a light bulb went off, and I started to realize, okay, maybe I didn't get into medical school, but maybe this is not a bad pivot. It's an opportunity to really contribute to the medical field, to the medical specialty. And so in '94, I started in the biomedical engineering program in India, found that I was really fascinated by it. I think in around my third year, I started to realize that what I really appreciated was the opportunity to converge computers with technology for medicine.
Which I want to interject here.
Yeah.
I think a lot of individuals don't realize, so when they think of AI, what's AI have to do with biomedical engineering? I think one of the beauties is that for this discipline, you can bring in so many other things like computer science, like mechanical stuff, and all of these other pieces. So I wouldn't have thought of computer science being tied to biomedical engineering.
Yeah, absolutely. And in fact, one of the opportunities I had during my third year of undergrad was to do an internship in a hospital. And that actually really brought home to me that I was really surrounded by biomedical engineering. I mean, your MRI scanner, your CAT scanner, I got to see these machines up close and personal for the first time and started to appreciate, wow, this is huge. But at the same time, as I was being trained to become a biomedical engineer, the wheels started slowly turning. And I started to look at all this data that was being generated, and I was starting to get passionate about programming. And I started to look at this and said, there must be an opportunity here to start to bring some of that computer-based analysis to look at these images. So I wrapped up, I finished, and I think I had an idea at that point. I wanted to pursue this in greater detail. Was fortunate to get a master's position in biomedical engineering at the University of Texas, where I went, and started to really hone in on skills relating to computer vision, image analysis, machine vision. Completed my master's and then realized that I needed to be in a center or in a place which had a hospital so that I could really start to apply these algorithms, these methods I was developing, these computer methods, to real clinical data. And that's when I got into the PhD program at the University of Pennsylvania. And from there, really, I think it started to come together because I worked very closely with clinicians, back to your point about the multidisciplinarity. And something I try to impress on my trainees and students is that as a biomedical engineer, by definition, you're working as part of a team, and you're really imbibing knowledge from multiple different streams. You have to be a good engineer, but you have to be able to appreciate the unmet clinical need, which means you need to be able to work with physicians, with clinicians, with doctors to really understand what is that unmet clinical need, and then start to develop a solution that is going to resonate and be aligned with what the physician needs.
Yeah, that's critical. So what brought you, and I love the tie to, for a biomedical engineer, how valuable it is to be in an environment that has access to both engineering expertise as well as a clinical setting. And I think of Georgia Tech and Emory as one of those amazing environments. One of the reasons I love our department so much. Tell me, because I know you stopped a couple of places before you came to Georgia Tech and Emory. Tell us a little bit about that journey and why you came here to Atlanta.
Yeah, I think I might have already given you the answer. I think a big part of the draw to Atlanta, to Georgia Tech and Emory, was the fact that I wanted to be in an environment where I was in close proximity of outstanding technological expertise. At the same time, I wanted to make sure that I was also in close proximity and embedded within a clinical ecosystem where I had the opportunity to interact closely with physicians but have access to the data. But critically, what I also wanted was a way of taking the advancements and taking the innovations from the lab and deploying it within the clinic. And that was really critical to me. So made a few pit stops along the way, built the lab, taken some of these technologies, through companies, through startups, taken it out. But I really found that what I needed to be was in an ecosystem, in an environment where the innovation could be translated directly into the clinical workflow. And that's why I feel what we have here at Georgia Tech and Emory with the Biomedical Engineering program really offers that opportunity. It offers us trainees who are trained in this sort of unified ecosystem where they're constantly exposed to technology, they're innovating, but at the same time, they've got a really solid grasp of the unmet clinical need. They're working closely with physicians. but they really have a deep appreciation of the translational pathway, which I felt perhaps was not as explicit or perhaps appreciated as much in some of the other places that I've been.
And for some people might not know what an unmet clinical need, what that actually means. Can you kind of describe that a little bit more?
Yeah, sure. I'll go back to the breast cancer example. This idea that you have women with early stage breast cancer, but not everybody really requires chemotherapy. So how do we identify which subset of women are truly going to benefit from chemotherapy versus those women that are not going to benefit from chemotherapy? It took me a long time to really understand that deeply, to understand what that actually means, to think of it, the way a clinician would think about that problem and articulate it. And I think that was part of why I love being a biomedical engineer, because without realizing it, we're trained to be multilingual.
Yes.
We're trained to wear different hats. You can talk technology, you can talk engineering, and then at the same time, talk to a clinician specifically about that unmet clinical need. What is the specific clinical problem where technology can address or provide a solution for a problem that has not yet been solved? Being able to understand that, being able to appreciate that, having a communication with a physician about that was so important and so critical. And I think it's that multilinguality that I find very impressive about our trainees in the training that they're receiving here in the joint program in biomedical engineering. The one thing I'll say about the unmet need also is that you have to have a grasp of because the unmet need very rarely is a fixed unmet need. It also continues to change because treatments change.
Right.
Because the
our
way we
population
manage
is aging,
our population
food is
ages.
changing.
I'll give you another example. In 2000, when this molecular test came out for breast cancer to figure out which women benefit from chemotherapy, it was hailed as a huge revolution in precision medicine because we didn't have many tests at that point. This was a test that could tell you whether you needed chemotherapy or not. The problem was, it was and is an imperfect test.
Right.
And it was only in 2021 that data finally came out showing that this test, after having been out in the market for 20 years, didn't work in black women. Because the way the test had been trained had not been diverse enough to incorporate a sufficient plurality of the population. And so that's what I mean, where the unmet clinical need, you only realize later on that it's not a fixed unmet need. You have to constantly think about the solution in a way that caters to the subsequent questions, or to come up with sort of the next generation or the expansion of the technology to address the solution that perhaps you thought you'd addressed, but in hindsight, you haven't completely addressed in totality. And so I think that that's another thing that as a biomedical engineer, you have to appreciate is that very rarely have you completely solved the problem. That the problem, there are nuances of it, there are pieces of it that you have to go in and address, and you have to constantly keep appreciating, where the field is going, how treatment and management for women, in this particular case with breast cancer, how is that evolving? And really thinking about, what are the next set of questions? What are the next set of challenges that have to be addressed?
I think going back, I love the example of the black women in this instance too,
Yeah.
because I think it also ties to what a lot of the population doesn't understand is why clinical trials are so expensive. And one piece of that and work that the FDA has done to require diversity plans in clinical trials. Okay, and so what it's doing is it's saying, okay, we want to make sure whatever you're testing in people from all different races, ages, areas that they live in, because that can be impacted by many things. And then for someone who has experience running clinical trials, that also means you have to include so many more hospitals and so many more settings and so many of those things in order to get to that. But the information that we garner from that is so vital because you have these instances. Okay, let's dig in a little bit more about funding for your research. Now, and I also want to tie to the unmet clinical need is just a reminder that really what I say to some of my students is, I want you to find something that is a real world problem that you're going to try and address and make an impact on as soon as possible. So let's talk about the funding. Like, how do you run your lab? How do you get the money to be able to support the work that you and your team are doing?
Yeah, so almost 95% of my lab is supported through federal funding. So it is supported through the National Institute of Health, through ARPA. These are federal agencies where we submit grants.
What is ARPA?
ARPA is the Advanced Research Program, and it essentially is modeled based off DARPA, but it's specifically around medical technologies and medical devices. And so this is a relatively new federal agency that is tasked with really spurring innovation in sort of a catalytic kind of way, where they really want to infuse funds, significantly more funds than NIH grants typically, but they really want to see momentum and movement to translation in a very short time frame. So the vast majority of funding that we have in our group comes through ARPA, through the National Institute of Health, and largely through federal agencies. Additionally, I'll also call out the CDMRP, the Congressionally Directed Medical Research Program.
Okay, and for our listeners who want to learn more about those agencies, we will include links in the show notes for them. Okay, so what would happen if you didn't have that funding?
If I didn't have the funding, then unfortunately I'd have to close shop. I'd have to leave. I'd have to close my lab for the most part. I wouldn't be able to support the graduate students in our biomedical engineering program and in other engineering programs at Georgia Tech, for instance, and at Emory. I would have to lay off the postdocs who are working in my group. Yeah, essentially I'd just have to shutter doors.
Which I think that the impact of that too, when you, every scientist that I speak to, I learn about their journey and then where they go to next. So can you talk a little bit, because over the span of your career, through the many different places you've been, you've had a lot of students that have gone on to do different things. Can you tell me a little bit more about where some of those individuals are today?
Yeah, absolutely. So I started as a faculty member about 20 years ago, in fact, exactly 20 years ago. And over the course of my 20 years, I've mentored over 200 trainees, including postdocs, graduate students, and I think about 27 PhDs so far. And of the 27 PhDs, I think there's sort of interestingly, a roughly equal split between those who chose to go into industry, those who chose to go into academia and become faculty members, for instance, and another third that were more entrepreneurial and have gone on to start companies or have taken technologies developed in the lab and actually translated them. One of them I'll call out, Dr. Nate Brayman, was a PhD student of mine who graduated in 2021. And in 2021, I started a company called Picture Health that was focused on moving AI technologies and bring them into the clinic for cancer patients. And I remember we were starting the company and I wanted a chief scientific officer. I wanted somebody who was really going to drive, a chief technology officer was really going to drive the AI piece of it. And Nate at that point had just started working in another company. And I reached out to Nate and I said, let's have dinner. So he came and I told him about this company. And it took about 30 minutes, you know. And I think the next week he tendered his resignation. He came and joined the company. Company today has about 16, 17 employees. We had a milestone last week because we put out a publication from the company that essentially is a reflection of the work that Nate did during his PhD thesis. And to me, that was so satisfying because the work that he did in the lab, he was able to now bring it into a solution, into a translational solution that we hope will actually start to be used in patients very soon. So really full circle.
Yeah,
you know,
that's amazing.
It's it's been great. I mean, several students have gone on to do that, but Nate is one who's probably top of mind because of his engagement with this company.
You're like a proud father.
Yes.
You know, the thing I love about what you were just talking about that too is that when we think a lot about research that's done in universities, we actually forget often all of those people who were involved in that research, and as subsequent being involved in that research, learn skills, become creative, go into different avenues, such as working for different companies that are then going to also build those companies into success, hire people, expand and mentor additional people as well? Because you talked about the 200 people that you've mentored. Okay, let's see. We're going to have like thousands of people that are going to come from the work that you've done, which is amazing. Okay, really quick, I want to learn a little bit more about you as a human. So what do you do in your free time? What do you do that really balances off the nerdiness of the science into some other areas?
Well, in a past life, I trained in speech and drama with the Trinity College London. So in a past life, I was an aspiring thespian. I did a little bit of acting. So today my go-to is to, catch a show, go, watch a play, go watch a musical. I do that. My son now is 14 and we actually go hit the gym. So that's sort of our thing to do together. And that's been very enjoyable. But the truth is also, I really enjoy what I do. I really enjoy hanging out with my trainees. I think we have a run through the Winship Cancer Center that's coming up in about a week's time. So, we've set up a Madabhushi lab team, and we're all going to run together.
Oh, that's amazing. Yeah. Okay, so can you tell listeners how, first off, they can find you, how they can follow your lab and the incredible work that you're doing?
Absolutely. So, I think I'm available on most of the social media platforms. I'm certainly on LinkedIn. If you search for my name, Anant Madabhushi, you should be able to find me on LinkedIn. I'm on X as well, handle @AnantM. And again, my email is anantm@emory.edu. So, happy to respond to emails, people reaching out, asking about, information about the lab. Happy to respond. Yeah.
Well, thank you for all the hard work that you do. It's amazing. I've loved watching your journey. I know of a couple of your stops. I've talked to some of the previous colleagues there, and it's just amazing, inspiring. So very grateful. Thank you.
Thank you. Thanks.
That's it for this episode of Holy Shift, Biomedical Breakthroughs Shaping Tomorrow. If today's conversation sparked your curiosity, pass it along to someone eager to explore the power of research to change lives. As a reminder, the opinions expressed in this podcast are those of the host and guest and do not represent those of any organization mentioned. Be sure to follow or subscribe wherever you get your podcasts so you never miss an episode. To learn more about the research featured on this show, visit bme.gatech.edu. or check the show notes for links and resources. Thanks for listening, and remember, behind every innovation is a purpose, a person, and a powerful story.